Good morning, everyone. At the outset, let me thank Dr. Puneet Verma for giving me this opportunity, and let me congratulate him for starting a structural heart disease program in this part of the country, and for his Watchman device, which was the first Watchman in this part of the country. My talk is on trans-catheter valve therapies in India. It is about trans-catheter aortic valve replacement and trans-catheter mitral valve replacement therapies. And I believe this is the hottest topic in the field of medicine, not only in the field of intervention cardiology, how we can replace a valve without opening the chest. Let me share this important slide with all of you. What do you think is the most deadly disease? Severe inoperable aortic stenosis, lung cancer, colorectal cancer, breast cancer, ovarian cancer, prostate cancer. Any guesses? The 5-year survival rate of severe inoperable aortic stenosis is 3%. Lung cancer 4%, colorectal cancer 12%, breast cancer 23%, ovarian 28%, and prostate 30%, which clearly shows that severe inoperable aortic stenosis is a deadly disease. There is no medical therapy for aortic stenosis. The only treatment is valve replacement. As of now, we keep following these patients with medicines, and this slide clearly shows that medicines don't work in aortic stenosis. This is the whole spectrum of patients with valvular heart disease which we see in our clinical practice. You would see patients who are extreme risk for an open heart surgery. Let me specify that again. The risk is risk of a patient who is supposed to undergo an open heart surgery. So an extreme risk is if the risk is more than 15%. High risk is 8% and above. Intermediate risk is 4 to 8%, and low risk is less than 4%. And this is the mortality risk. What is an extreme risk patient? The patient has 15% chance of dying for an open heart surgery, and we don't do anything for these patients because they are so advanced into their natural history that whatever you do, they will die anyhow at 1 year or 2 years, and that is because of other comorbidities and not only aortic stenosis. So the whole trial started. Initially, the trials were started in the high-risk patients, which was a US core valve and partner high-risk study. In the intermediate risk patient population, we had SIR-TAVI and PART-2 trial, and in the low-risk trial population, we had Notion trial. Again, since the high-risk trial, which was started in 2008, we have been moving down to the low-risk and intermediate risk patient population. The TAVR was US FDA approved in high-risk patient population in 2013-14, where the transfemoral TAVI was not inferior to an open heart surgery. I'm not going to go into detail of that, but I'm going to start with the PARTNER-2 trial, which was the intermediate risk patient population. Initially, people were saying that TAVR is only for patients who are inoperable. No. In the intermediate risk patient population, interesting data at 2 years, when valve was replaced from the femoral artery, it was statistically better than an open heart surgery in terms of all-cause mortality and disabling stroke. The other important thing was, did the valve last long? This is just from the US core valve SIR-TAVI trial, which is the intermediate risk trial, and at 2-year follow-up, the trans-catheter valve replacement was hemodynamically equivalent, or in fact better than a bioprosthetic implanted by surgical AVR. This is the slide which clearly shows as the technology and the therapy has evolved from 2012, the complications have come down. Like life-threatening bleed has come down from 6.9% to 2.4%. Major vascular complications have also come down. The stroke rate has almost remained the same. It has remained the same from 2.5 to 2.2 or 2.2 to 1.8%. And maybe we can discuss why it has so is because the average age of patients who are undergoing TAVI in the high-risk patient population was 83. The average age of a patient in a intermediate risk patient population was 79 for a self-expanding valve and 82 for a balloon expandable valve. And we already discussed in the Watchman presentation that age itself is the strongest risk factor of developing a stroke. The mortality with transcatheter valve replacement, in the early data, it was 6.8% and 5.8%. Now it has come down to 2.8%. In fact, with the latest generation valve, as of now in 2018, the mortality is less than 1%. There was a paper which was published 2 weeks ago where they compared TAVR in low-risk patient population versus open heart surgery. In TAVR patient population, 30-day mortality 0, stroke 0, pacemaker 0, compared to 1% in patient who underwent an open heart surgery. And why was the mortality higher in the earlier trial is because those patients were high risk. And this is a very important slide which shows that mortality is directly related to the STS score. And what is an STS score? This is the parameter which I shared with you earlier. If you have a higher STS score, you have a high chance of dying, irrespective of your valve disease. That is because you have so many other comorbidities. So as we move from high risk to low risk patient population, the TAVR outcome and result will be better. And this is how the TAVR was established in high risk patient population based on the US core valve and PART-2 trial. TAVR got an US FDA approval in intermediate risk patient population in 2016 based on the SIR-TAVI and the PART-2 trial, which showed that TAVI when done from the femoral artery is superior than open heart surgery. What about the low risk patient population? Notion trial, we have 5-year outcome now, which used a self-expanding core valve that TAVI is not inferior to open heart surgery even in the low risk trial. The latest low risk trial ongoing is PART-3 and core valve low risk trial, which is enrolling patients above age of 65 years. Very soon we'll be having very promising data which will show that if a patient is a candidate for bioprosthetic valve replacement, he will be a candidate for trans-catheter aortic valve replacement, and next 5 years, the dimensions is going to change. If you are high risk for TAVR, you go for surgery. I'm just going to share a few examples which is going to help us to understand what type of patient population in India will benefit from TAVR or has been benefiting from a TAVR. So this is a patient, 72-year-old patient, had a prior MI, PCI to LAD, AF, severe AS, EF of 25%, mean gradient 36, P gradient of 52, dimensionless index 0.12. I'm just going to stress on that. This is very important echo parameters, because in the past, we used to call severe AS only if mean gradient was more than 40 or velocity of more than 4 or peak gradient of more than 60. Now we have various parameters: low flow, low gradient, severe AS, low flow, low gradient, normal EF, severe AS, which is something called paradoxical severe AS. So a dimensional index really helps us to judge whether the patient has true severe AS or a pseudo severe AS. So we calculate it always. It is a ratio of LVOT VTI and aortic valve VTI, ILD, not on steroids, and frail. So this patient is high risk for an open heart surgery, but does TAVI make a difference? How do we evaluate these patients for transcatheter valve replacement? CT scan is must. Some people ask me the patient asks me, how do you size the valve? So, in the past, on an echo, you would measure an annulus and give it to the surgeon. Do you know any surgeons in the audience? Do you know what that measurement meant to the surgeon? Nothing. So how do they size is they open the aorta, put the patient on heart-lung machine, excise the valve, put a sizer there. So whatever the dimensions which we were giving on echo, 17, 18, 19, did not mean anything to him, because that is only one small axis which we are measuring on the echo. And that is why CT scan is must. Just seeing if I have my pointer. So this is not working. Okay. So on CT scan, we understood that annulus is not a circle, and that is why it has a short axis and a long axis. When the valve were being sized based on the short axis in the early part of TAVR era, there were a lot of perivalvular leak and embolization. CT scan changed the whole dimension. Now the valve is sized based on the perimeter. Yeah, you can see that. So valve is sized based on the perimeter for a self-expanding valve and sized based on the area for a balloon expandable valve. We look at the annulus, then we look at the sinus of valsalva diameter. Because another question which comes to mind, this valve which we put in place, can it obstruct the coronary artery? So the coronary artery fills by filling of the sinuses. So if sinuses are wide, the blood will fill the sinuses during diastole, and this blood will fill the coronary artery. Then we also look at the LV outflow tract, how it is. Suppose there is a lot of calcium in the LV outflow tract and it is narrow, we can have complications of complete heart block and LVOT rupture for a balloon expandable valve. We also look at the size of ascending aorta. You don't want to do a TAVI in a patient whose ascending aorta is more than 5 mm, because that is a patient who's going to require Bental or other corrective surgery. The other most important thing which we look on the CT scan is the size of the femoral artery, common iliac, external iliac, and the abdominal aorta. Let me tell you why. The earlier devices, the first generation devices, they used to go through a 22 French sheath, which is almost like 9 to 10 size when you look at the outer dimension. So the TAVI was being done from transfemoral, transaortic, transapical, transcarotid, various other approaches. In the trial, one clear message which we got is, it is the transfemoral TAVI with no vascular complication which actually made a difference. So if the size of the artery is small for a particular sheath which is required to deliver a valve, then you know what all precautions you need to take. The other thing is, whenever we talk about French sizes, 6 French, 8 French, 10 French, it is the ID, the internal dimension of a sheath which we are referring to, and it is actually the outer dimension of a sheath which will make a difference. Once the CT scan is done, then this particular patient also had an LV apical clot. And why I'm stressing on this is because all these patients will have so many comorbidities that such things are not usual. So I'm going to skip technical details, but what we did is we put a spider filter, protected the coronary blood flow, protected the cerebral circulation, 2 spiders, and then went ahead, deployed the valve. This is how the valve looks like. This is a self-expanding valve, which has a porcine pericardium, leaflet, and is supraannular. Here's a pigtail which is parked at the annular plane, and this is slowly opened up and deployed. This is again an aortogram which we take to make sure there is no leakage of the valve, and this is an echo which is done on table. Similarly, these patients, they go home on 3rd day, and that patient has completed 1 year. Another complex population which we see in these patients is presence of concomitant coronary artery disease. So this is a female patient who has severe AS, valve area of 0.4, mean gradient of 90, and normal LV function. But this is what I want to share with you. Just to detail, this is the calcified ascending aorta, arch, and the thoracic aorta. We call it as porcelain aorta. Surgeons cannot operate on such a patient. And the reason why they cannot operate, if you have to do an AVR, you have to put a clamp. And there is no place to put a clamp in a calcified aorta. And this is again an ostial calcified left main. And the idea is, because this patient population is a complex patient population where you would have concomitant CAD and severe AS. It becomes very difficult for us to decide what to treat. But one thing is for sure, as I shared with my slide earlier, it is the severe aortic stenosis which causes symptoms in these patients. So we don't treat any mid-LAD or OM or diagonal or an RCA lesion, but definitely in this particular patient, the ostial left main was, the treatment was required. We did a complex ostial left main PCI and valve replacement in the same sitting. And why in the same sitting is again a very debatable issue, because these patients, they cannot tolerate these procedures multiple times. So we went ahead and did a PCI and valve replacement in the same sitting. This patient has completed 1 year follow-up, no hospitalization, and is independent of her daily activities. Is it only for elderly? No. This is basically for patients who are intermediate to high risk for a redo AVR, for a valve replacement. This patient, 45-year-old, 150 kilogram, already had a valve replacement in the past. So you can see this mechanical mitral valve, and this is a new valve which is being placed without open heart surgery. So these can also be done in patients who have mechanical mitral valve prosthesis, not in the aortic position. And this slide I'm presenting with the permission of the patient is, this is the same day, this is evening of the same day when valve replacement was done. He was sitting in his bed, had his dinner, and the next day he was out of ICU. So the trans-catheter valve replacement, when done under conscious sedation, has really made a difference in this patient population. What about Indian technology? This is very important, and it's a proud moment for all of us that we have an Indian transcatheter heart valve, and this is the first in man case which I did 1.5 years ago. 82-year-old patient, severe AS, NYHA class 4, hypertension, COPD, AF, STS score of 7.6, and we presented at TCT. This is an aortogram, balloon dilatation, a balloon expandable valve was implanted, and we did a femoral angiogram to make sure there is no bleeding. This case was done under conscious sedation. This patient is from Abhor, Punjab. This is again taken with permission, And this is the second day he was walking, and he was discharged home on third day. We have completed the first in-man trial of the Indian valve. 30 cases have been done, and I'm going to share some of the data of the Indian outcome at 30 days and 6 months. And this is just a one slide, which is I'm going to share how the patient looks, or he's talking to us at the end of the procedure, and he's saying in Hindi that what happened to mere purane valve ka kya hua, aur ye screen pe kya dikh raha hai. And this is at 1 year of TAVR 1 year of TAVR. And the reason why I'm sharing this slide is we're doing this TAVI under conscious sedation, and how it helps is that one of the important complications of a valve replacement is stroke. So we assess neurological function on table before patient leaves the cath lab. And one such patient was not able to move his right upper and lower limb, and we did a DSA on table, found clot in the middle cerebral artery. The clot was aspirated, and patient started moving his limbs on table. Now suppose I'm doing this case under GA, which I do only outside my hospital. I would prefer to extubate these patients on table and do a neurological assessment fully. This is the first in-man trial of my valve, which is a balloon expandable valve indigenously produced in India by Merrill Life Sciences, and I presented the data at the EuroPCR of this study. We enrolled 30 patients, and this was the follow-up 30 days, 6 months, 1 year, 2 to 5 year. I'm the co-principal investigator of the study. These were the sites which were involved in the study. We did the highest cases of my valve. The average age was 75. The 22 patients were male. Average STS score was 6.4. Majority of patients were symptomatic. 43% had CAD, prior MI in 4, prior CABG in 5, PCI in 4. These are the various comorbidities which we find in this patient population. And this is again a CT scan. It is must. We had a patient with creatinine of 3. Would you do a CT scan? Yes. If I'm doing a TAVI, we have to do a CT scan, because otherwise we are all blinded that what is going on inside the heart. We would take help of Dr. Manish Singla and great nephrologist to help us to do these CT scans. But this is again what all we look on CT scan: aortic annulus, LVOT, coronary height, sinus or valsalva diameters. This is the my valve which were used during the study population. 4 patients got 29 millimeter valve, 2 patients got 20 millimeter valve, 13, 23, and 11, 26. Pre-dilatation was done in 87% of patients, and this is the follow-up data. The mean gradient before procedure was 47, post-procedure was 5, 30 days 6, 6 months 8, 1 year almost 10. Peak gradient almost remains same, velocity remains same post-procedure, EF remains same. This is very interesting. Aortic regurgitation. None of the patient had severe aortic regurgitation, and only 2 patients had mild paravalvular leak. What about the mortality? So we had 0 device-related mortality during the first in-man 30 patients. However, there were 1 death due to kidney injury, and another one also because of the vascular access site complication. We had 1, repeat hospitalization was again seen in 3 patients, and at 30 day in 1 patient. We had access site complication in 4 patients, and that is because this device goes through a 20 French sheath. This is how the valve looks like, and this is how the landing zone is. I'm not going to go into technical detail. The reason why we had 0 pacemaker in our trial, I mean, it's a very small number to really conclude on anything. It's just a first-in-man safety study involving 30 patients. But the reason why it was 0 pacemaker is all our valves were implanted 3 mm below the annular plane. And just the technical detail, the conduction system fibers, they go 5 or 6 mm below the annular plane. So if you're not too deep in, you will not interfere with the conduction fibers. And the initial TAVR data with the Medtronic core valve, which I was part of the study in US, we had pacemaker rate of almost 25 to 30%. And the reason is because we were implanting these valves a little deeper. We were 6 to 8 mm below the annular plane, and that is why we had high pacemaker. So this is just a small number. We need to do a long-term follow-up. So the conclusion was no new device-related events observed till 6 months. All patients are hemodynamically stable with consistent echocardiographic assessment. The first in man, which I shared with you, has completed 1.5 years, no hospitalization, mean gradient remains same, 0 device-related mortality, and no permanent pacemaker implantation. And I'm going to share this with you. This valve got DCGI approval last month, and now it is available for commercial use as well. What about transcatheter mitral valve therapies? Just going to share this example with you, which is going to help us to understand where we are. 56-year-old lady, diabetic, hypothyroid, had a mitral valve repair in 1995, had a 25 millimeter pericardial magna valve in 2007, and now presents with bioprosthetic valve degeneration. I'll just pause here for a minute, and I'm going to share with you one of the thought process which goes in my mind is, all of a sudden, everybody started scrutinizing the TAVR valve, which is a bioprosthetic valve. In our clinical practice, we have seen surgical bioprosthetic valve being degenerated in 7-8 years' time, and especially if it was implanted in a mitral position. We never saw I have never seen a bioprosthetic valve lasting for 20 years. And this is going to throw more interesting data, because from the TAVR field, what we have learned is, we have learned a concept of bioprosthetic valve thrombosis. And I believe this also existed in the surgical bioprosthetic area, and it was actually being called as early degeneration, and patients were undergoing redo cardiac surgeries. So now we have started putting these patients on anticoagulation if patient has increased gradients in the bioprosthetic valve, and slowly those gradients disappear. So this is again degeneration of a mitral bioprosthetic valve. So we don't have a transcatheter valve for a native mitral valve position. It is still under trial. But what we have is an FDA-approved indication, is a valve-in-valve therapy for a degenerated bioprosthetic mitral valve. And this is how it does. We do a transseptal puncture, go from the right atrium to the left atrium, orient our valve, and go ahead and deploy this valve. This is again a 70-year-old lady, hypertensive, diabetic, prior cardiac surgery, and a bioprosthetic valve regurgitation, tricuspid regurgitation as well. Look at the mean gradient of 17 and severe TR. We again do a CT scan in order to understand what is the size of the bioprosthetic valve. Is it going to interfere with the LV outflow tract or not? And then we plan for a valve-in-valve using a 26 millimeter valve, which is an indigenous valve. We do a transseptal puncture, go from the right atrium to the left atrium. You saw that transseptal puncture technique on the Watchman presentation as well. This is a transesophageal echo probe. The site of the transseptal puncture is very important for structural heart disease intervention. When we do a BMV, we don't even look at imaging. We just go ahead and puncture the septum, cross the valve, and I believe there are all experts in the audience who would do a BMV in just 5-10 minutes. But for these structural procedures, we need to be very precise where we are actually puncturing the transseptal. Not going to go into details. We put a confida wire into the left ventricle, and then we go ahead and dilate the septum. Why I'm sharing this particular slide with you is, I initially tried to go in with the valve, and we had difficulty crossing the septum. I went again to the surgical note on table, and I found out that surgeon had replaced the mitral valve by going from the right atrium. So it's very important for us to understand how the previous surgery was done. Because if surgeon went from the right atrium, he actually opened the septum, and from septum he went to the mitral valve side, and he had put some sutures in the septum. I had to use a bigger balloon to break the suture site in the septum. Most of the mitral valve replacements are being done from the left atrial side. So very important to understand how the previous surgery was done. 3D transesophageal echo is must. This is how we position the valve. This is how the valve is inflated, deployed in the correct position, and the lower part you see a new mitral valve in place. This is how it looks on fluoroscopy. This is the valve frame. The leaflets are inside. It is a bovine pericardial leaflet, and this is the echo. The mean gradient initially was 17, which you saw, is now 4, and I'm going to play this for you. No mitral regurgitation. This is the first case in the country of transcatheter mitral valve using indigenous valve. This patient was discharged home on 3rd day. What about the tricuspid valve replacement? After undergoing a transcatheter mitral valve replacement, because this patient also had severe TR, what we do is we wait for a month, because the tricuspid leakage might be because of the bad high PA pressures and because of the high LA pressures. And because these patients cannot undergo a redo surgery, let me tell you, the right-sided cardiac surgery is more complicated than a left-sided cardiac surgery. You would never find a surgeon who can easily operate on a tricuspid valve with RV dysfunction. It carries very high mortality. And this is just a slide which I'm going to share where we did a cable valve implantation. Cable valve, it is implanted at the junction of IVC-RA. And one problem which we face in patients who have severe tricuspid regurgitation, I mean, everybody sees that, is these patients, they come with symptoms of right-sided heart failure, ascites, hepatomegaly, deranged LFT, pedal edema, and most importantly is low cardiac output state. You keep giving them diuretics. You can decongest them, but if you give more diuretics, the cardiac output of right ventricle is preload dependent, and they'll have features of low cardiac output, and then slowly they'll start developing complications of high diuretic dose. So this particular therapy protects the visceral circulation from the tricuspid regurgitation. And the valve is anchored at the level of at the diaphragmatic hiatus. There is a skirt which is kept above the level of hepatic vein. This is a wire and a catheter in the hepatic vein because you don't want to occlude the hepatic venous flow. Then we do an RA angiogram. There's no reflux into the hepatic vein, and then a hepatic venous angiogram to confirm that the flow of hepatic vein is not obstructed by the valve. This is again an echo which shows the cable valve leaflets moving and the venous flow. This is again a hemodynamic tracing pullback. You would see a large V wave in these patients, but when you pull back, there's no pressure in the IVC beneath the valve leaflets, which shows that the valve leaflets are working fine. This was the first trans-catheter double valve replacement where we did a 23 sapien from Edwards and a cable valve implantation for 35 millimeter trick valve. The other interesting trans-catheter valve therapies for mitral valve is this very interesting patient who had a perforation in the anterior mitral leaflet, and I presented this at the India Live as well 2 years ago. Now this patient has completed 2 years of follow-up. What we did is she was diagnosed with severe valvular mitral regurgitation. And very important, if you have a severe MR, we need to do a transesophageal echo to really understand what is the mechanism of mitral regurgitation. And this patient had a perforation at the base of AML. We closed it using a Emplazer vascular plug, and that patient has completed 2 years follow-up. There's another interesting transcatheter mitral valve therapies, which is also available here, which is a PVL closure, where you can identify where exactly is the leakage around a bioprosthetic or a mechanical valve, and you can close these leakages by using vascular plugs, either from a transeptal approach or from a transapical approach. I'm going to skip this because this is already discussed. And this is our last few slides. This is our TAVR experience. We've done 192 TAVR at EHCC Jaipur. We have completed 59 TAVR. This is the data of EHCC Jaipur. The mean age is 73. Bicuspid valve was 9. EF of 40%. Pacemaker requirement was in 3 patients. Major vascular complication 1. Only first case we did it under GA. All other under conscious sedation. All patients are percutaneous using a ProGlide. 1 patient had a stroke, and 30-day mortality was 0. 60-month mortality, 1 patient had a sudden cardiac death. We don't know what was the reason, but at home she died in the toilet. Most likely could be an arrhythmic death only. And thank you very much for your kind attention. I think I'm just going to share one because I have some time left. I just saw 45 minutes of presentation. I thought everybody will be bored. So I'm just going to share one case in box. So not going to detail, but I'm just going to just look at this room, how many people are working on one particular case. This is me right here, and this is my cardiac surgeon. People say that, do we need a cardiac surgeon for all these transcatheter valve procedure? If I'm operating out of Jaipur, I don't really find cardiac surgeons in the hospital, but here I would have my cardiac surgeon in my room, scrub, for 2 particular reasons. Let me tell you. Number 1, Because surgeon is in the room, the OT is vacant. You never know what can go wrong. And the number two, because surgeon feels part of the procedure, if anything goes wrong, like suppose there is a vascular complication he needs to repair, he's going to be happy to do that. If you don't make him part of your team and then you call him when the complication happens, you know how he's going to be talking in the whole corridor. So very important that a cardiac surgeon is part of your team, and we would work, these are my junior associate consultant cardiologist, and then you would have scrub nurse, one scrub nurse. And this is, I'm going to share with you, is the Python sheath. This is the expandable sheath which can expand from 16 French to almost 14 French to almost 20 French. It is in the pipeline of development, and very soon we'll be having that data. So I'm going to just go to the few important slides. This is a pigtail catheter which comes from the femoral artery to the level of aortic annulus. You see that heavily calcified mitral annulus. This is the patient population which you see. And then we cross the valve. This is a temporary pacemaker which is positioned in the right ventricle apex. Very important for a balloon expandable valve, because if a pacing capture is lost, the valve can migrate. This is how a stenosed valve is crossed. I use an AR2 catheter and a straight tip thermo, and there straight it goes into the ventricle. Once we cross, we would position it at the apex. Very important. One important complication which we see in a TAVR, which can happen in a TAVR patient population, is the LV perforation, and that is disaster. These patients will die on table. And then you do a pigtail and do a hemodynamic assessment. Let us see if there's a hemodynamic assessment which comes on this screen. See, so many things are ongoing. There's an echo doctor who's doing an echo for us, and this is a stiff wire which is implanted in the ventricle because you need support for the valve to go in. This is a balloon which comes. We need to pre-dilate, make some space for the trans-catheter valve to go in. Again, this is a controversial topic. Some people don't prefer to pre-dilate. I would pre-dilate if the anatomy is suitable or favorable. I'm just going to share this with you because this is an important thing. And we would rapidly pace. You see, we would rapidly pace these patients. And see, once the blood pressure goes down, if you focus on the hemodynamics, see the blood pressure is down to almost 20 to 40 millimeters of mercury. Then we would dilate, and then we would go ahead and stop pacing again. And see, one important question is, does pre-dilatation cause severe AR? I haven't seen severe AR happening with the patient is moving the limb because he's under conscious sedation. We haven't seen severe AR because balloon is sized based on the short axis of the seat annulus, and if the balloon is smaller than the short axis of the annulus, it will never cause tear of the leaflets. And that is why all these CT scan imaging actually helps us. And this is how the valve looks like. This is a balloon expandable valve which is crimped over the balloon, and then we go across the arch. And this is actually the step where the stroke can happen. You see that heavily calcified arch, and you saw how the valve was rubbing against the arch, and that is how a plaque can be lifted up and it can go to the brain. Once the valve crosses the arch, then there's something called a deployment angle, which is derived on the CT scan. We would come to that angle, and we would go ahead and cross the valve. This is a live case which we are doing, and once the valve reaches the annulus, you see that hemodynamics which is going on, and you know who is managing that hemodynamics right now? The anesthetist is not a general anesthetic in the room. He's a cardiac anesthetist. And what I tell him is, you be prepared as if you are doing a surgical AVR. So he has his NORAD, ADR, they love Milrinone, everyone, whatever they want. They want 10 drips. If you go to a cardiac surgical intensive unit, you would see 10 drips going on simultaneously in a patient. So how it helps is that I'm focusing only on my procedure. So he takes care of all the hemodynamic tracing. And then once we place, see, the pigtail is one point on the annulus, and the annulus is a hypothetical plane where neither of all three cusps are in a straight line. And once we are satisfied with the position, then this valve is implanted into rapid pacing. And this is what I'm going to share with you again here. See, the wire position is so important. It is always in front of our eyes. Once we lose focus of the wire, that is the time it is going to go through the LV apex and it can perforate the left ventricle. We take one more picture, one more aortogram to confirm. So even if you ask a surgeon what an annulus is, there's nothing which you can touch and say that this is the annulus. No. It is actually a hypothetical plane where neither of all three cusps are in a straight line. And that hypothetical plane we identify based on the CT scan. So what we look at is all three sinuses should be separate and easily identifiable, left, non, right. And then they should be in a straight line. Because if you cannot see all three sinuses, the valve deployment will not be at the correct position and will have valve embolization, perivalvular leak, or I'm going to just pause here. So this is the non-coronary sinus, this is the right coronary sinus, and this is the left coronary sinus. So all of the sinuses are seen at the same time. And now you would see, I'll be implanting the valve, and this is where, I want you to focus on the hemodynamics. What happens is that we would pace at 180. And initially, we were, initially in the initial trial valves, everybody was, scared of the hypertension which would happen. But I would say this is like, just consider this is a 15-second of ventricular tachycardia. So you're going to rapidly pace. So see, you rapidly pace, blood pressure goes down. Still, I'm not deploying the valve. I'm waiting for a sustained response. The blood pressure is low. You begin inflating the valve. Go ahead and fully inflate. Still the blood pressure, then you deflate. I'm still not stopping the pace. Once the balloon is fully deflated, then you stop pacing. And then you ask your anesthetist to help with the blood pressure recovery. And then we go ahead and remove this balloon. So this is a time of adrenaline in your body because you don't know what is going to happen. So blood pressure comes back, everybody's relieved, and then we would ask the echo doctor to help us with the echo. You saw how, and then immediately you do an echo. You're looking at two things. Is there a perivalvular leak? Number two, is there a regional wall motion abnormality? Because if there's a regional wall motion abnormality, you need to treat it immediately on table. This is the mean gradient post-procedure 3. And single-digit mean gradient is acceptable for all our TAVR patients, and they do fantastic. We go ahead and remove these things. The hemodynamic stabilizes, the blood pressure stabilizes. And this is an aortogram which we would take before we remove the wire to make sure there's no complication which has happened. Because if there is anything required, we already have a valve, you can go ahead and post-dilate, you can go ahead and treat if the valve is low, high, and various other things which can happen. Yes, and then you put a pigtail, do a hemodynamic. This is the tracing which you should be getting. No peak-to-peak gradient and a good diastolic separation. If aortic diastolic and LV DP are away from each other, that means there is no significant leakage. And then a final aortogram. Again, I'm going to share, this is how the valve is implanted. See, this is the annular plane, and this is just 3 millimeters of valve below the annular plane. Once the valve is fully implanted, we do it percutaneously. We go ahead and deploy the proglides. There is no cut down, and take a final angiogram. Thank you very much for your kind attention.
Thank you, Dr. Ravinder, for an excellent talk as usual. And I think this is the most exciting time to be in intervention cardiology with so many new procedures coming up with Tower leading the way. I would like to set the ball rolling. Now there are so many Tower coming up. Self-expanding we have balloon mounted, now portico is coming up. Now is there any specific indication where you would be looking for particular valves or depends on what's available? That's one question to begin with.
So that's a very important question because now there are so many technologies which are coming out. So as I said, sir, the most important thing which made a difference in the TAVR population is the transfemoral TAVI. So what I'm going to look at is, first thing I'll look at the femoral artery of my patient. And then I would look at which valve can go through that femoral artery. So if you look at the Medtronic Evolute R, all you need is a 5.5 millimeter vessel, a Sapien, which is an Edwards balloon expandable valve, requires a 6.5 millimeter vessel. Portico again needs a 6 mm vessel, 18 French. And my valve at present, because it is 22 French, needs almost an 8 mm vessel. And then this is how I would select. The second one is balloon expandable versus a self-expandable. We can go, there are multiple things which helps us to really decide. But one important thing, which you saw in a balloon expandable valve was rapid pacing. Can my patient tolerate rapid pacing? Suppose patient has low ejection fraction, 15%, 20%, has bad CAD, which I don't want to treat. So I don't want to rapidly pace them. If my patient cannot tolerate rapid pacing, then the answer is a self-expanding valve. But now, for all other patient valve in valve, aortic position, I would use a self-expanding Evolute R. The reason is that is a supraannular valve. So if you put a leaflet inside a bioprosthetic valve at the same level, the effective orifice area will be less. But if you put a valve inside a bioprosthetic valve where the leaflets are above the lowermost frame, you can get a good effective orifice area. For non-aortic position, the only valve which can be used is a balloon expandable valve. If a patient is young, and I think that that patient has a baseline right bundle branch block, and I don't want him to leave the hospital with a pacemaker, I would use a balloon expandable valve because the pacemaker rate was higher in a self-expanding valve. And definitely the cost, what the patient can afford. Sometimes, you know, the FDA approved valves are very expensive, as you know, as of now. The cost is $30,000 US. And it's unfortunate that it's being translated into Indian currency. But yes, that's also an important factor.
That was really excellent, sir. Considering that many of the audience are physicians, I would like you to answer, why not in rheumatic valves? Because our target population is majorly going to be rheumatic.
Yeah. That's again a very important question. Why not rheumatic heart disease? Now, as I shared with you, the TAVI is a bioprosthetic valve. So if a patient is a candidate for a bioprosthetic valve, he can be a candidate for a transcatheter valve replacement. But look at the rheumatic population. Most of them are candidates for mechanical valve. So that is the reason why we are not doing a rheumatic heart disease. But as I said, I just shared one patient who was just 45-year-old, 150 kilogram, had a mechanical mitral valve, and now had an aortic stenosis. That patient actually has an element of rheumatic heart disease. So it is not that we cannot do under rheumatic heart disease, but if anybody with a rheumatic heart disease above the age of 65, it's like a mixed picture where there's rheumatic heart disease, some age-related calcification, degeneration. But if patient is a candidate for bioprosthetic valve, they can be candidates for TAVI.
So you think in the coming years, we could move on to rheumatic heart disease, especially aortic valves, being replaced by TAVI?
Again, depends on the age. So again, let me tell you, so low age and low risk, they are two different entities. The risk of an 80-year-old healthy individual would be just 3%. But if you move to the low risk, low age, something like a 40-year-old, 35-year-old, I would not give a TAVR to them. In fact, I would give them a bioprosthetic surgical valve, which can last a little longer, and then we can do a valve-in-valve TAVR in this patient population. And this is the latest generation surgical bioprosthetic valve is being manufactured. That valve, the frame of the valve has got actually hooks and sutures. That means at 10 years down the lane, you can crack the valve frame and put in a trans-catheter aortic valve with better hemodynamics.
And for the young cardiologists, what do you think is a critical level of TAVRs which we should do to be able to be confident enough to do them on our own?
So we don't have any specific guidelines in India as of now, but in US, I can share the guidelines there. You need to do minimum 50 TAVRs a year in order to start a TAVR, you need to do a structural fellowship. But now in order to maintain a TAVR practice, you need to do 50 TAVRs a year. And now let me tell you in India, actually, I feel it depends on the expertise of an individual, because we as Indians are more skilled than US, there is no doubt about it, as an intervention cardiologist. I would say minimum of 10 cases, but you should be doing other structural interventions like BMV, septal punctures, handling large bore catheters, large bore sheaths. But I think minimum of 10 TAVRs will give you an idea what actually is going on. Otherwise, when you're doing with a proctor, it's like you're driving a car where somebody is giving you instructions right and left, right and left. But I think 10 cases would be enough. And then if you keep doing 10 to 12 cases a year, I think that should be fine. But you need to build a team, which I have seen has actually helped me a lot to build this practice in my city. You need to have surgeon, always on board, and never think him to be as a competition for you, but rather than as a friend. Because what I have seen that suppose you advise TAVI and patient goes to a surgeon, and I'm just sharing this thing, and surgeon would say, why would you spend 25 lakh rupees? I can operate you. Fantastic, surgeon will operate. But that patient's outcome depends on the recovery from the open heart surgery. If you look at technical surgical AVR is very easy. You open the chest, put him on heart-lung machine, remove the leaflet, suture the new valve. But it is a recovery in terms of renal failure, infection, lung infection, prolonged ventilation, and stroke, which affects the outcome. So I think that's an important thing.
Dr. Ravinder, you presented a couple of cases where you used protection,
Yes.
cerebral protection, and US is becoming common to use
Yes.
to prevent an embolic episode. Are there specific indication we are looking for? There's some anatomical features where you would use those cerebral protection, or you feel that's an option?
So again, very important question, sir. One important slide which I shared with you is since 2012 to 2018, what actually has changed is the vascular complication has come down, the pacemaker rate has come down, hospital stay has come down. But what you saw is the stroke rate remained the same, 2.8, 2.2, 2.4%, something like this. So let me tell you, if I have the dedicated device for cerebral protection, which is called Sentinel device, I would use it in all patients. But if I don't have a device in India, which is not available, then I'm looking for a very specific patient population, something like, as I showed, LV apical clot. Number 2, porcelain aorta, heavily calcified aorta. Number 3, patient who has a baseline carotid disease. So the workup for a TAVR patient is same as a workup for a surgical AVR. You do CBC, RFT, urine routine, ultrasound, carotid Doppler, angiogram, PFT, serum albumin, and TSH, all same. So if patient has a baseline carotid disease, then it becomes a very challenging. Then I would not put a filter crossing that lesion. I would prefer to put a filter in the common carotid artery. But if I have a dedicated device, I would use it in all patients, because you never know in which it will happen.
But the problem is going to be all the distal protection devices which we have are 6 or 7 millimeters,
Yes.
which may not be sufficient for a common carotid. So
Exactly.
there's going to be a challenge technically there. So that
I think it's going to come in India in a couple of months. The device is called Sentinel device, which you go from the radial artery. I was part of the trial in US, very easy to use. It's like a filter which is implanted in the brachiocephalic trunk, and other the filter which is implanted in the left common carotid artery. Still the vertebrals are unprotected, but there's multiple devices which are coming up, deflectors and all those things, but we have to wait for the device.
I think tower is going to stay and the number is going to increase, and most of the physicians here are going to see cases of aortic stenosis. So I'm sure you would have a number of questions to ask, which patients to refer for and how to proceed on for tower. So any questions from the audience?
And sir has already started a TAVR program, is that correct, sir? Yeah. Congratulations. So, one important thing just I wanted to share, you know, when I was giving a talk in a IMA session, there were physicians and doctors who said, you know, medicine se chalta rehta hai aortic stenosis to. So that's why I shared that slide, you know, medicines don't work in AS. We have there's 1 to 2% chance of sudden cardiac death in symptomatic severe AS. It's a long asymptomatic phase, as we know from the Braunwald curve, but once the symptoms begin, the average survival is just 2 years. If you have dyspnea, 50% of them will die at 2 years.
Another thing we need to remember, it's never too late to operate or replace a valve in aortic stenosis. Whatever may be the left ventricular dysfunction, these patients are going to improve. So we should never give up, even if they have critical aortic stenosis and with a severe left ventricular ejection fraction 10 or 15, we must offer them an option. Dr. Puneet is giving indications now. Thank you, Dr. Ravinder, for a wonderful talk.
Thank you so much.
Let's give him
Thank
a
you,
big hand.
everyone.
Thank you so much, sir, for such an educational session. Now, I would request Dr. Puneet Verma to please present the mementos to our respected speaker, Dr. Rao. Our chair faculty, Dr. Bali. Our chair faculty, Dr. Navreet Singh. Now, I would like to hand over dice to Dr. Puneet Verma for the inaugural address.
Good afternoon, everyone, and thank you for gracing this occasion. Just for those who don't know me, I'm Dr. Puneet Verma, and I'm a cardiologist by profession. Not really an entrepreneur by choice, but yes, was forced into it to become one. And therefore, my passion still remains that I prefer saving human lives over any other option which would be presented to me. And that's the reason that I like to associate with people who believe in this mission, resultant of which we see that there is a fantastic lifesaver faculty with us in this CME Matters of the Heart, who believe in this mission. You've heard a lot of people this morning, you've heard the chair faculty speak, and our common mission is always that we believe in saving lives. And one of the other reasons that all you people are here is because we like to create an environment for people who gel into this, in which people worthy of your caliber, your status, and your professionalism like to come and attend these meetings. So I'm very grateful and thankful to all of you for gracing this occasion. It's a great day today to be sharing science with you. In the last 11 years that we've been able to work in the Tri-City and set up this tertiary cardiac care facility, I must thank my very dedicated team of medical, paramedical, administrative, and allied staff who have helped me in these last 11 years. Dedicated both in terms of service, dedicated both in terms of values. And that is something which is very rare to find and persist with and consistently deliver to patients' expectations over a period of 1 decade. I really do not need to explain my mission value. You can maybe stop any of our staff out assembled here, and they'll be very happy to answer your questions or what our mission and vision is all about. It's undoubtedly that when we practice medicine, the needs of our patients, they come first. There is little doubt about it. And that's the sole reason that we exist in a society. We believe that we must practice evidence-based medicine for the betterment of our patient care and health. And this CME further consolidates the reasons why and our principles of care as to why and how we wish to, we plan to, and we've been following all these principles in the times to come and have practiced it in the past. There are 3 reasons for me to be here. One, of course, is to welcome you all. In this, I would certainly like to acknowledge the very gracious presence of our very esteemed faculty, whether it's the speaker faculty, Dr. Mohan Nair, Dr. Muralidharan, some of the people who have made into this conference for the first time, Dr. Ravinder Rao, an excellent orator, Dr. Arun Chopra, about whom you will hear more in the post-lunch sessions. Dr. Pannu, who as the sole cardiac surgeon has been here. He came a bit late, but I'm sure he would have enjoyed the first half of Dr. Ravinder Rao's lecture, which he unfortunately missed. I'm very thankful to Dr. Bali, Dr. B.S. Bhatia, Professor Sapru, and last but not the least, with whom this meeting was made possible, Dr. Sanjeet Singh Sodhi, the president of IMA. My second purpose, of course, was to tell you briefly about myself and our hospital. And the third and most important reason why I stand here is to introduce and welcome you, all the audience, to 3 very gracious luminaries of the region who have graced this conference, namely the very dynamic Deputy Commissioner of Mohali, Mrs. Gurpreet Sapra, the very diligent and hardworking civil surgeon of Mohali, Dr. Mrs. Rita Bhardwaj, and the very purposeful Vice President of the Punjab Medical Council and an orthopedics by profession, Dr. Girish Sani. So I welcome you all to this meeting, and I'm personally obliged for your presence. You will get to listen from them in the next few minutes and maybe get to interact with them as well. So I wish you all a pleasant day, a great day for the conference, a great year ahead. Remember, 2019 is probably going to be the last year with teens in our lives. So please remember that and have a great day and a great year. Thank you very much.
Let's proceed with our inauguration ceremony by lighting the honor of lamp. I hereby invite our honorable guests, Mrs. Gurpreet Sapra, Dr. Rita Bhardwaj, Dr. Girish Sani, Dr. Professor R.P. Sapru, Dr. S.S. Sodhi, Dr. B.S. Bhatia, Dr. Ashwini Kansal, Dr. Shikha Verma, and Dr. Puneet Verma to please join us near lamp. Thank you so much, all present here. Now I would request TC ma'am, Mrs. Gurpreet. I'm sorry. Now I would request Dr. S.S. Sodhi to please address the audience.
A very good afternoon to the dignitaries, faculty, and the delegates. On behalf of IMA Mohali, I would like to congratulate Dr. Puneet Verma, ACE Heart Institute, and the team for this annual organizing of the conferences, the matter of the heart. The plus point of this conference always has been that it has topics which are of interest to the common clinician, to the specialist, and also to the interventionist, including the surgeons, apart from cardiologists. So a very big hand for that. And as President IMA Mohali, I would take every opportunity to reiterate that in changing times, doctors need to be more united, more organized, maybe even aggressive, while carrying out their duties with all sincerity. For this, I would say that doctors who are not members of the IMA should become the members of IMA, and those who are members of the IMA should attend each and every activity of the IMA as part of their duty. I would like to again congratulate Dr. Puneet Verma for the academic feast that is unfolding and wish him all the best for this and all the future endeavors. Thank you.
Now I would like to invite DC ma'am, Mrs. Gurpreet Sapra, to please address the audience and infuse the audience with her grace.
Good afternoon, everyone. Dr. Puneet, as always, I am really stumped as to what to say, because such brilliant brains are sitting here, and I am not a doctor. Of course, I am in touch with some senior doctors here for a variety of reasons, but all I can say from my side is, Dr. Saab, wonderful, commendable activity, and this is my second time in the row for having attended this. Much learning happens, and I wish you and the hospital the very best for the future. Great job. And for all the doctors and the guests sitting here, as an administrator, all I can say is that if at all we can be of some assistance to you in taking these initiatives forward, we are always around. Thank you so much. Thanks again. Thank you.
I would now request our guest of honor for the day, Dr. Rita Bhardwaj, to please address the audience.
Very good afternoon to all. It is indeed an honor to be among the presence of so many senior cardiologists of the Tri-City and nearby areas, and from far and wide also. And it is also so great to be even looking at the wonderful things that are being done nowadays. I wish all of you the very best, and congratulations to Dr. Puneet for holding such a good CME. Thanks.
Thank you so much, ma'am. I would now request Dr. Girish Sani to please address the audience.
Honorable Chief Guest of the Day, Deputy Commissioner Mohali, Mrs. Gurpreet Sapra, respected guest of honor, Civil Surgeon Mohali, Dr. Rita Bhardwaj, other dignitaries, ladies and gentlemen, a very good afternoon. It is indeed my great pleasure and privilege to be present amidst you this afternoon and to take part in this CME. It's a matter of honor and great achievement on the part of ACE Heart and Vascular Institute Mohali and Indian Medical Association Mohali to host the 7th annual CME Matters of the Heart. The main objective of the CME is to put the spotlight on the main issues and challenges faced by the cardiologists across the country, and to bring awareness among the people to change their lifestyle in order to stay away from the cardiovascular diseases. So it is indeed a moment of great pride for all of us. You all that you have gathered here, at the very outset, I would like to express my compliments to you all that you have gathered here to discuss your vision, common heart problems, and how to address these problems. Ladies and gentlemen, non-communicable diseases are the leading causes of adult morbidity and mortality worldwide, and India is in the grip of epidemics posed by the non-communicable diseases like cardiovascular disease, respiratory disease, diabetes, and cancer, which are lifestyle diseases caused by unhealthy diet, sedentary lifestyle, mental stress, and use of tobacco and alcohol. As per Lancet Global Health October 2018 report, India's burden of NCD is escalating at an alarming rate. The burden of communicable diseases was more than 50% in 1990s. But now the trend has totally reversed, and the NCD account for 55 to 60% of burden of all diseases. And it accounts for 62% of all deaths in India annually. The major culprit among the NCD is cardiovascular disease, which constitute about 28% of all NCDs. The alarming increase in incidence of heart disease is a matter of concern to everybody. Ischemic heart disease is the leading cause of death in Punjab. We are not only the diabetic capital of the world, but ischemic heart disease capital as well. It is sad to see an old father bringing his young son to the hospital with heart attack. By 2020, India may account for 60% of world's heart patients. In gearing up to meet such eventuality, a lot of responsibility lies on the shoulder of cardiac specialists like you. In 2010, the government came up with a national program of preventive and control of cancer, diabetes, cardiovascular disease, and stroke under National Health Mission. And now it has come under the Ayushman Bharat to take care of all NSDs. The focus is to bring awareness about the behavioral changes, dietary practice, physical activity, smoking, and alcohol. Ladies and gentlemen, in 2016, Ministry of Health and Family Welfare capped the prices of stents and knee implants. However, cutting down the prices or capping certain procedures may compromise the quality, standard, efficacy, and success rate. However, government is under legal obligation to ensure the access to life-saving drugs and rationalization of prices of quality medicine and medical devices. Just because someone is poor, government cannot allow him to die. So there is a big need to bring down the out-of-pocket expenditure in India, which is around 70% of total health expenses. So government is contemplating a middle path so that the patient should not be deprived of the latest technology as well. Punjab government is also working on a different modalities and has taken all the stakeholders on board, especially Punjab IMA, to bringing a doctor-friendly clinical establishment bill. Ladies and gentlemen, you all know the advancement of technology has brought in creativity and innovation in the medical field, so much so that we are able to diagnose, tackle the various dreadful diseases which were once a distant dream few decades ago, as we have made a great progress in telemedicine, telecardiology, and of late telerobotic coronary artery surgery. But the ground realities are somewhat different. Our overall healthcare delivery system in India is not very encouraging. Not only the NSDs, we have been facing many other health problems and professional problems as well. We have a very high maternal and infant mortality rate. We have a huge problem of drug abuse in India. There has been a deterioration in the standard of medical education. There has been a huge problem of quackery and unfair trade practice, which is eating our society like termite. This quackery is a main cause of the growing mistrust in the doctor-patient relationship. So we have been waiting for the day when our healthcare delivery system becomes fully accessible, affordable, accountable, equitable, and reliable. And most importantly, when for the safety of doctors, safety and security of the doctor will be the main concern. Only then we'll be able to achieve our aim of universal health coverage under the Sustainable Development Goal number 3 of United Nations. For that, we need to bring a successful and sustainable healthcare model which incorporate robust and effective health insurance policy, or we may need the help of a public-private partnership which take care of cure, cost, connectivity, and compassion. Ladies and gentlemen, this cannot be achieved till we increase our healthcare budget from 1.15% to 2.25%, till the commercialization of the medical education is stopped, until the health awareness reaches the last person on the ground, until most importantly, till the doctors have fear of CPA while taking up a difficult and serious cases in their hospital. Not taking much of your time, I congratulate Dr. Puneet Verma and Dr. Sanjit Sodhi and team for organizing such a wonderful academic feast. The discussion here, I'm quite confident, will enrich your clinical experience and enlighten you regarding the contemporary cardiovascular and legal medicine. Thank you very much. Thank you.
Thank you so much, sir. Now I would request Dr. Puneet Verma and Dr. Sanjit Sodhi to please jointly felicitate our honorable chief guest, Mrs. Gurpreet Kaur Sapra. Our guest of honor for the day, Dr. Rita Bhardwaj. Our special guest, Dr. Girish Sahani. To resume the session again, may I please call upon Dr. Mohan Nair, Coordinator and Head Cardiac Science, Holy Family Hospital, New Delhi, to present the ACE oration. And to co-preside the session, I welcome on dais Dr. Professor R.P. Sapru, former Head of Cardiology, PGI Chandigarh, Dr. Arun Chopra, Director of Cardiology Sciences, Fortis Escorts Hospital, Amritsar, and Dr. Sreenivas Reddy, Assistant Professor of Cardiology, PGI Chandigarh.
Mohan Nair, please.
Mr. Chairpersons, ladies and gentlemen, a very good afternoon. It's indeed been a great honor for me to present this ACE oration, and I cannot thank Puneet enough. But I think that far more than thanking him for the oration is the fact that I've been a teacher, and for a teacher, even one single student performing as well as Puneet is reward enough. I'm not saying this just because Puneet invites me year after year for his conference. This oration is indeed an honor, and the honor is greatly multiplied by the fact that it is being chaired by a legendary teacher, cardiologist, Dr. Sapru. Thank you, sir, for chairing this session. In many conferences across the world, when we have sessions on arrhythmia and invasive treatment for arrhythmias, the question asked is, why do you have to actually go so aggressively again towards ensuring sinus rhythm? And the best, smartest answer I've got is from Francis Margatroyd, who was an Anglo-French electrophysiologist working out of London, who said that most of us were created in sinus rhythm. And what we are naturally created is the best thing to have, whether it be rhythm, whether it be blood pressure, whether it be weight, or anything else. And that's why ensuring sinus rhythm is so important. Being an oration, I will restrict my talk entirely to my own work and publications. This is a 25-year-old gentleman who had come to us with this ECG. He had just landed his dream job of being a train driver in the Indian Railways. But at the last step in the medical examination, when his ECG was taken, this was seen, and his job was rejected. He did have history of some palpitations, but being a young man, that just bothered him a little bit. He would take rest, never had to go to a hospital. But the recorded palpitations were this. His heart rates were going up to 200. So what would you do? One, there's a young man who says there's nothing wrong with me, and I went through all other tests to get to this job. The other is that none of you would have your engine driver having this while he's driving the train that you are in. Medicines wouldn't take away these ECG abnormalities. They could suppress, but never cure. We knew from early studies that this form of ECG abnormality and fast tachycardias occurred because in addition to the normal conduction system, these patients had an accessory tissue somewhere in the heart, and when there was a re-entry circuit between this accessory tissue and the normal conduction system, the heart rates went up, just like a short-circuiting in any electrical circuit would lead to sparking. And therefore, we just needed a technology which would go to this place and destroy this extra tissue. And this is how we do it. This is a transseptal puncture. Take this ablation catheter, the special catheter, to exactly the place where the accessory electrically conducting tissue was there. Apply what is called as radio frequency energy, and see this. This is one of those old systems. As you can see, there's tremendous disturbance in the channel, but you step on the paddle within a few seconds, before you blink your eyes, this ECG abnormality is normalized. And this is normalized for life. So the young man goes home with his disease cured and his dream intact, with his job intact. We also knew that soon knew that the other common form of supraventricular tachycardia, that is narrow QRS tachycardia like this, without this ECG abnormality occurred because the normal AV node, which has single conduction properties, had longitudinal dissociation of conduction, and therefore could conduct in some parts in a slow way and then conduct in another part in a faster speed. And as soon as you have two sets of tissue which have different conduction properties, that sets the tone for re-entry tachycardia. And this again, this is the right atrium, this is the His bundle, this is the coronary sinus. The normal conduction starts here, goes down to the AV node, and then to the different parts of the two ventricles. We knew that this was the area where the compact node occurred, that was normal and essential for normal conduction. The abnormal tissue was somewhere in between the coronary sinus here and the His bundle here. And if we were able to selectively destroy reducing radiofrequency current in this area, then these patients were again, by and large for life, cured of this tachyarrhythmia. This is a young girl who was admitted not too long ago, about a decade back. But at my age, a decade is very short, you know. I'm several decades old. So this young girl, Pooja, was admitted with progressive dyspnea, palpitations, heart failure for 12 months. There was cardiomegaly on X-ray. Echo showed an ejection fraction of 20%. And this was what the ECG was. At one
one casual look, you would say that this is a sinus tachycardia in a patient with myocarditis or dilated cardiomyopathy. A closer look shows that this is not actually sinus tachycardia. The P waves are inverted in 2, 3, and AVF, and there's those pointed P waves in AVR. The other thing was that she was persistently in this tachycardia. Unlike sinus tachycardia, again, like nature, moves with your needs. So what would you do? The first step was, again, accept the fact that she has a chronic myocardial disease, try to control the arrhythmia. And this is a message which everybody should know. If you have a combination of LV dysfunction with arrhythmia, please be more aggressive and believe that the arrhythmia is contributing, if not is entirely responsible for the LV dysfunction. You lose nothing by getting these patients back into sinus rhythm. Even if it is dilated cardiomyopathy, they do better in sinus rhythm. But if these patients are actually patients are like this, then it's criminal not to have treated the arrhythmia properly. So this patient was put on amiodarone, this child. Sinus rhythm was restored, and the LV function improved. So the diagnosis of myocarditis fitted in, and after a couple of weeks, she was taken off amiodarone, and then bang, she was back into this arrhythmia. She was then taken up for curative ablation. We put these catheters with multiple electrodes. At that time, we needed multiple electrodes to see where exactly this arrhythmia is coming from. Take the ablation catheter to the place where we mapped the atrial tachycardia, and the tachycardia was gone. See this here again. Within a few seconds, this tachycardia, look at the rate, at this, stops, and normal sinus rhythm is restored. This is the sinus rhythm ECG. The LV ejection fraction, this is the beauty of some of these technologies. Within 5 days, almost before hospital discharge, she went home with a normal ejection fraction. She was on follow-up with me for 7 years. After that, there's no need for her to be on follow-up with me. And hopefully, she is now married with her own children. So what is this magical radiofrequency catheter ablation? Just for the uninitiated, let me tell you, that is just nothing but radiofrequency current, that is sinusoidal current that is passed at a frequency of 500 hertz. That's the same frequency that is used for FM radio transmissions. That's perhaps why it's called radio frequency, that is passed to a catheter, through a catheter, and between a catheter that is placed in the heart and a dispersive electrode that is generally placed on the skin around the shoulder of the patient. And when this current is passed through that catheter, it causes what is called resistive heating and causes a very specific localized area of destruction that destroys the electrical properties of that tissue that you want to destroy. There's very little destruction of any other tissue around. So it's a minimally invasive procedure that's done under mild sedation, takes about 1 to 2 hours to complete, and unlike many other chronic diseases in cardiology or in the entire field of medicine, these chronic structural heart problems are cured by this. So when we talk of success rates, we are talking of cure rates. Cure rates exceed 95%, in fact, close to 99% when they are used to treat supraventricular tachycardias. Are there risks? Certainly there are risks because you're inserting catheters inside the heart. But on the whole, of all the procedures still done in cardiology, this is considered the safest. A pacemaker is needed in less than 1 in 200 cases. That too, generally during the learning phase. If you've done a few thousand cases, you rarely end up needing a pacemaker because you accidentally damage the AV node. Serious complications that require blood transfusions, etc., are extremely rare. Death is an accident. You have to be extremely unlucky to be having a mortality while doing these radiofrequency catheter ablation procedures. As with cardiology, we just heard from aortic valve, we're moving to mitral valve, to tricuspid valve. While we were able to cure supraventricular tachycardias, we were also going to address more complex arrhythmias. And one of them was atrial flutter, that we all know has these sawtooth continuous waves in the inferior leads. And this is a circuit we didn't understand initially. The circuit was actually described by Puig, who's a brilliant French electrophysiologist who, who was one of the first actually to record his bundle potential in human being. And Puig had described that typical atrial flutter or common atrial flutter is a purely macro-reentrant circuit within the right atrium. And the good thing was that in this macro-reentrant circuit, in the whole of right atrium, there was this anatomically distinct area between the tricuspid annulus and the inferior cava, which was discrete and also essential for this circuit. So if you were able to destroy this tissue electrically between the tricuspid annulus and the IVC, then you would get rid of flutter and get sinus rhythm again. I was lucky, actually, this is one of those tracings. You find atrial flutter, plenty of atrial tissue, and bang, the flutter is gone when you apply radio frequency energy. I was lucky to spend some time in clinical fellowship in France with a man who actually did the first-in-man flutter ablation, Nadir Saudi. It's the same lab I was just discussing with Dr. Rajiv. That's the same lab where the first-in-man transaortic valve replacement occurred also by Alain Cribier, again a genius. While working there, we were able to further modify the flutter ablation technology, not only get to termination of flutter, non-induction of flutter, but also define specific electrophysiological parameters which would ensure that not only was flutter gone on that day, but would never occur in that man in his life ever again. So the recurrence rate of flutter, which is a complex arrhythmia, came down from being around 20% to less than 5%. Back in India, this was the first publication of flutter ablation in the Indian soil from G.B. Pant Hospital. And we did actually continue to work on fine-tuning flutter ablation because it was an interesting arrhythmia and also important arrhythmia to treat. This was a child, I think, was admitted when Puneet was still training with us. It was a child, 3 years old, referred from Rajasthan. Was found to be in incessant tachycardia, wouldn't sleep, would be consistently crying, would not eat, was not growing. And the QRS morphology actually is typical of a ventricular tachycardia that can happen in normal hearts. Ventricular tachycardia is something that you normally associate with abnormal hearts. There are 2 or 3 types of ventricular tachycardia that occur in normal hearts. And if you take care of the ventricular tachycardia, the child is as good as normal as anybody else. So this is a ventricular tachycardia. As you can see, there are these capture beats coming from the RV outflow tract. And those who were there in the lab with me, a few seconds of RF ablation in the right ventricular outflow tract just under the pulmonary valve, and the tachycardia was gone. I was a little surprised, but looking back, I thought, this child is so small, the catheter would have covered half of his outflow tract anyway, so you didn't need to be very precise in mapping. But again, this child was cured. That's the tachycardia going on. Again, sinus rhythm restored during RF ablation. Idiopathic, the other form of tachycardia that occurs in a structurally normal heart is the idiopathic left ventricular tachycardia, which again, most of us, whether we are physicians, cardiologists who are non-invasive or non-interventional, or interventional non-electrophysiology cardiologists must recognize that is right bundle branch block, left axis deviation. There's another tachycardia in the same right bundle branch block, left axis, just done a couple of days ago, last week. See, you have these capture beats. These tachycardias actually occur around the fascicles, that is the distal conduction system in the left ventricle, and therefore, if you're able to go and map and destroy some of this tissue in the perivascular area, these people are cured of this ventricular tachycardia. This is how the catheter would look. Go along the septum, the conduction system goes always along the septum, and somewhere in between the distal 1/3 and middle 2/3, you find these fascicles, and you can ablate and destroy the tachycardia. The initial endpoints of this ablation was termination of tachycardia during RF ablation and non-inducibility RF after the procedure. However, we presented this data in the CSI meeting sometime. Despite getting good maps, despite having fascicular potential, despite having acute success rates, there was a recurrence rate of 13%, which was not acceptable for an RF procedure. In fact, many others reported recurrence rates of more than 20%. So we looked again more to see if we can improve the results. If you see here, there's a sharp potential. This is the ventricle, QRS. This is a ventricle. There's a sharp potential. That's a fascicular potential. And as you apply RF energy, the fascicle potential moves away. That there's a conduction delay between the fascicle or the distal end of the fascicle and the ventricle, and you would get increasing delays and even increasing degrees of block between the fascicle and the myocardium. We then applied this to 15 patients in a prospective manner and followed them up from 1 to 3 years and found not a single recurrence. This was published in Heart Rhythm, which is the official journal of the Heart Rhythm Society of the US. So we now have so far discussed avinodal reentry tachycardia, accessory pathways, atrial flutter, idiopathic ventricular tachycardia. But what about those difficult tachycardias? Atrial fibrillation, ventricular tachycardia in structural heart disease, and of course, ventricular fibrillation. These were difficult to treat purely because these occurred in variable and distorted substrates, and the arrhythmia circuits were often complex. This is a cartoon of what an arrhythmia circuit in a scarred ventricle could look like. You can have multiple places, and you can spend the whole day trying to find out which exactly is the circuit that is responsible for a tachycardia. So it was not surprising that some of these tachycardias were difficult to treat. Just when everything looked hopeless, came this seminal article from Bordeaux, France, in 1997, where Michel Heiseguer described that although atrial fibrillation was chaotic, most patients who had paroxysmal atrial fibrillation had their atrial fibrillation triggered by extracardiac thoracic vein, particularly the pulmonary veins. So if you could not map and ablate the atrial fibrillation, you could at least map and stop the triggers. Once the trigger is gone, these patients would not have atrial fibrillation again. And we just heard about how bad the atrial fibrillation could be in terms of oral anticoagulation, LA occlusion device, et cetera, et cetera. Get rid of the atrial fibrillation by a simple ablation procedure, no drugs, no LA device, no oral anticoagulation. So this is a school teacher, actually, who came all the way from Kerala to me, and he could not take classes because without any warning, while taking a class, he would get into atrial fibrillation. So this is a catheter that maps activity in the pulmonary veins, and you find a lot of activity in the pulmonary veins initially. That's all gone after the ablation. So the pulmonary veins are electrically isolated, and sometimes while you're giving the pulse, the atrial fibrillation converts to sinus rhythm. What about atrial fibrillation in structural heart disease or rheumatic heart disease, as was discussed even during TAVR discussion? Yes, we were interested in mapping and trying to see if a similar triggering factor at least could be found in atrial fibrillation and rheumatic heart disease, which affects population in this part of the world specifically even now. And we found that although rheumatic atrial fibrillation was a very, very well-established atrial fibrillation, the beginning of atrial fibrillation again could be mapped best because there were flutter circuits that occurred around the atrial septum or the coronary sinus. And this was published in 2001 in Circulation. Although the initiating arrhythmia was good, but this was not good enough because there was too much of structural abnormality already in the left atrium. Thereon, what helped us to tackle arrhythmias that involved structurally deformed abnormal heart were these 3D mapping systems. 3D mapping systems actually were mapping systems which used either a magnetic field or impedance changes and tracked the catheter movement within a ventricle or within the chamber of the heart, and you could not only recreate three-dimensional views of the chamber in question, you could also get voltage maps to see where the scars are. You could get propagation maps to see how the circuit moved. And this is all non-fluoroscopic. This looks like a video game, nice, beautiful video game. No fluoroscopy, but extreme in-depth knowledge about the chamber that is being targeted. Just as an example, the atrial flutter actually looked like a clutter of catheters initially, but if you see here in the propagation map, the 3D mapping, you can clearly see the rotation within the right atrium. Just follow this trace there. And then the IVC being activated passively. Or compare that to a focal arrhythmia in the atrium where the arrhythmia arises from a single focus. I showed you the fluoro pictures for idiopathic left ventricular tachycardia. If you had 3D mapping, you could actually tag from the left side of his bundle to the left bundle branch block, posterior fascicle, and then target the RF ablation distally. All this could be mapped upfront. If you see here, there's tachycardia going on in the lower panel. As soon as this catheter touches the target point, the tachycardia is broken. The other technology that we adopted, unlike many other centers in the world, we were the first in India certainly, and among the first in the world to adapt this technology was rotational angiography, or what is called as Dyna-CT by Siemens. And what this does is that when you are doing a conventional angiography, the C-arm moves 180 degrees and takes slices and recreates a CT-like anatomy of the heart. You could then use this CT-like anatomy segmentally, and imagine this is real-time 3D available on fluoro. Improves your catheter movement, increases safety, and you know exactly where you're going. You could segment it further in case of a pulmonary vein isolation to just have the pulmonary vein that you want to ablate and see how deep you are and whether you are right at the ostium where you want to ablate. So using these technologies, we were able to move further. And this is the ablation that we started then doing in chronic atrial fibrillation in rheumatic heart disease. And we were able to also, of course, ablate left atrial or atypical flutters. This was published in 2009. It took us 8 years to move from the first publication to this publication in chronic atrial fibrillation in 2009 in American Journal of Cardiology. This again was one of the first publications on ablation of chronic atrial fibrillation in man. Moving from atrial fibrillation to VT in structural heart disease. This is again, everybody can see this. Now this is a chamber of the right ventricle in a 3D mapping system, and this is the map during ventricular tachycardia. You can clearly see the place from where the VT is originating, and you ablate that. Then, when you re-induce, there's another tachycardia that comes up, and this had to be cardioverted, because ARVC or cardiomyopathies are patients who do not tolerate, and this system just requires one beat for you to be able to know where it is coming from, and you ablate the tachycardia. Our experience with radiofrequency catheter ablation in arrhythmogenic right ventricular dysplasia was again published in Journal of Interventional Cardiac Electrophysiology. What about VT in the common disease that you see, coronary artery disease. That's the VT that the atrial fibrillation. Whenever you talk of atrial fibrillation, they say, what about atrial fibrillation and rheumatic heart disease? Always the difficult questions. When you say VT, you say, okay, fine. VT in normal heart, give isoptin beta blocker, they are doing fine. But what about VT in ischemic heart disease? In ischemic heart disease, again, with 3D mapping system, we could see localized areas of scar, and if there were small areas of scar, then you could isolate these areas, and the tachycardia would disappear and be non-inducible. This was a challenging case. 32 years male, extensive anterior MI, PCI was late, recurrent syncomal VT requiring DC cardioversion 18 months following MI. He had an apical aneurysm with LV ejection fraction of 20%, had been admitted in different hospitals, was intubated thrice before finally being referred to our hospital. And he had 8 different morphologies of VT, all of which were hemodynamically unstable. 2, 3, 4, 5, 6, 7, 8. So then, this was the first actually use of DynaCT in our in a ventricle. We needed this because we didn't want to go through the aneurysm and perforate or have a problem. We also needed to know exactly where the aneurysm is. Then when we map, you find a huge big scar. It's impossible to isolate this scar. Even if you do, the patient's ejection fraction, which is 20%, would then go down to 15 or 10%. But what is good is that if you actually see more carefully, there are these islets of scar which are actually separated from the main scars by these normal tissue that is seen in red or yellow. And it is these channels which actually form the reentry circuits. So one after the other, you meticulously block off these channels. What was gratifying was this gentleman was out of job for close to 2 years, had no money. We gave him a donated ICD. At the time of ICD implantation, when we tried to induce ventricular fibrillation for defib threshold testing, nothing was inducible except short burst of polymorphic VT, which means the ablation had worked. The patient then became well, moved to Mumbai. I had given him the numbers of some of my friends who were in Mumbai for follow-up because I was really concerned for this patient. He was lost to follow-up, but on a visit to Mumbai, I was very happy to see this interview by this young gentleman on a Sunday magazine saying how difficult life can be and how good it can be after a life-saving surgery. He went on to, I think, get married and even have a child. What if the patient had acute MI with storm? Not a chronic burnt-out MI, but can you do ablation of VT storm in acute MI? That's very difficult. This is a patient, again, 55 years old, extensive anterior MI, recurrent therapy of VT with unresponsive to DC shock, cardiogenic shock. When he was referred, his whole skin was all burnt out all over the place, up to the neck. And these were the VTs that he came with. And as does Puneet, I must say, whenever I have a difficult case, I do ring up some of my friends and say, do you have an idea? And I did ring up people in Canada, US, everywhere, and there's an acute MI. All they said was, best of luck. Nothing. Nobody had any experience because this acute MI is a cheese-like myocardium. You're going to put a catheter there, evolving substrate. But what could we do? We couldn't say best of luck to the patient. We had to do something. We went in, we were lucky. There were 3 channels we were able to identify very quickly. And you see here that there is this VT going on, all kinds of VT. But towards the end, as we ablate the channels, the VT becomes non-sustained and then slowly maintains sinus rhythm. This gentleman finally went home with an ICD with no more VT storms. So our experience of up to 5 years follow-up with RF ablation of ventricular tachycardia and structural heart disease is now published in Arrhythmia Open Access, which is a new open access arrhythmia journal. The last frontier, ventricular fibrillation. What do you know about the circuit of ventricular fibrillation? How many of you think that ventricular fibrillation can be ablated? Well, the good thing was that if you carefully look at ECGs of patients who come with ventricular fibrillation, initially in so-called idiopathic VF, this was a young lady. I'm so sorry, actually. This is the only slide with the identity shown. I'm sorry for that. That should not be done. Anyway, if you carefully see, idiopathic ventricular fibrillation invariably is triggered by ventricular PVCs. And as luck would have it, these PVCs again arise from two areas, the same areas that give rise to idiopathic ventricular tachycardia, that is the ROA outflow tract or the fascicular Purkinje system. If you're able to ablate these, the VF does not occur. Increasingly, it's been seen that VF, even in structural heart disease, that is patients who have acute ongoing ischemia and polymorphic VT or VF, a good number of them would have triggers within the Purkinje myocardial junction. So we just took this patient here. Again, if you see here, that's fascicular potential, and there's the ECG later on. There are a couple of couplets, no more ventricular fibrillation. So the list keeps increasing. Almost everything is done. But this is still in yellow because we've not actually have had the same kind of curative rates that we have in the top 4 arrhythmias, but we are improving. Going forward, till now, we knew where to go. We had the electrograms, we had the fluoro 3-dimensional matting to show us where the catheter was, but nothing told us what are the pressure that was there between the catheter and the tissue. That was important to get a transmural lesion and also to improve safety. Now we have catheters which give us what is called as contact force. A contact force, we know how much to apply for an effective pulse and how much to avoid. Once we have a contact force beyond a certain stage, we know that we have to back off, otherwise we would soon have a perforation. The other technology that we are increasingly using is looking at MR scans to look at scar areas, to look at LV geometry, LA geometry, etc. And our first paper is already ready on use of CMRI and on its impact. A lot of things that is, it's amazing how much a regular echo can miss and how much a cardiac MRI can tell you. And that can dramatically change the way you manage the patient. Just 2 more minutes, if it's all right. I didn't talk about devices. Ever since Mirowski put in this device in 1980, we know that an implantable cardioverter defibrillator is the best chance, the 100%, not RF ablation, 100% protection against hemodynamically unstable VT or VF. The problem was that these were bulky devices, and also that the initial devices were single chamber, which meant that their ability to discriminate between supraventricular arrhythmias and ventricular arrhythmias was not very great, and the patients would get up to 25% of the shocks were inappropriate, that were not for appropriate arrhythmia. And if you talk to a patient who has had an ICD shock, he would almost say that please take this device off. It's a terrible thing to have. I worked with the French company Ela Medical on an algorithm for differentiation of supraventricular and ventricular arrhythmias using a dual chamber ICD. All that we needed to do was to put another lead in the atrium which could record atrial signals. And this is a first-in-man. This is a first-in-man publication of application of a dual chamber ICD algorithm. This was followed by the Defender trial, which was the first-in-man actual device trial on dual chamber ICDs. So as we have moved on, These devices have become smaller, smarter, and are able to do far more than defibrillate or pace. They're able to treat cardiac failure, and of course, there are diseases that are being used even for neurological disorders. So in a sense, the growth of interventional cardiology, the improvements in device technology, and the availability of several drugs, both antiarrhythmics and anticoagulants, has opened a huge, huge opportunity to treat patients who have cardiac rhythm disorder. It has also given cardiac electrophysiology to become a very rapidly developing and important subspecialty of cardiology. Once again, thank you very much, Puneet, for this. My journey in interventional cardiology is now close to, let's say, a little more than 2 decades. And the journey has not been very easy. A lot of difficulties whenever you start a new specialty in India. But most important, the most difficult decision was for me, and Puneet would know, for me to take a few steps back from interventional cardiology. At that time, I was in the thick of interventional cardiology when a lot of interventional cardiologists, even in this room, were perhaps not even born. I took a few steps to focus on what was, at that time, looked like a hopeless, idiotic field. But now, looking back, I think I have a lot to be grateful for, because that step the whole journey has been exhilarating and gratifying. Gratifying because I think I have made a difference in the lives of a few people with distressing arrhythmias, and I think that in my own small way, I have contributed to the field of electrophysiology in India. Thank you very much.
Thank you, Dr. Nair. I think that was a wonderful oration. He led us through he led us through a very long journey. As you very rightly point out, some 40 years back, when cardiac electrophysiology made its humble origins, it was thought to be very complex, mind-boggling, and unrewarding. And that's why when anybody became a cardiologist, the aim was to become an interventional cardiologist, which meant doing angioplasties. But all that changed in 80s and 90s with the onset of radiofrequency ablation, which gave us so much insight into complex arrhythmias. We found out things which we had never known. And with the onset of newer technologies, newer ways of delivering therapy, 3D mapping, CT, MRI, cardiac electrophysiology has really taken giant steps. And I think Dr. Nair has had a big role to play in a lot of innovations and a lot of new things which came up in our country in this field. And I think we should congratulate him for that.
Thank you, Arun.
Thank you, sir.
Thank you so much.
Dr. Reddy. So with that, I think we should all give him a big hand. He deserves a standing ovation. Thank you.
That's really humbling. That is really humbling. Thank you so much. Well, that's the team I work with now, so I need to thank them, the unsung heroes of our work. Thank you, Puneet, once again.
Thank you so much, sir, for such a knowledge boost. Now I would request Dr. Puneet Verma to please present the memento to Dr. Nair, our respected speaker. Professor R.P. Sapru. Dr. Arun Chopra. Dr. Sreenivas Reddy. Lunch is ready. Please join us for lunch, and we join back for the session at 2:45. Welcome back. Moving on to the next session, I take the privilege to call upon Dr. Rajiv Bhardwaj, Professor, Department of Cardiology, Indira Gandhi Medical College and Hospital, Shimla, and Dr. Amit Verma, Consultant Cardiology at ACE Heart and Vascular Institute, Mohali, to join us as chair faculty for this session. And to conduct the session, I call upon Dr. Arun Chopra, Director Cardiology, Fortis Escorts Hospital, Amritsar.
Good afternoon, and welcome to the post-lunch session. We'll be starting with the session Dr. Arun Chopra has done. He's a former assistant professor cardiology from MEMS, and he's director for cardiology Fortis Escorts Hospital, Amritsar. His main interest is complex PCI device implantation, especially CRT, and he's in charge and training program for CRT. He has approximately 100 national and international cardiology publications, and he's program in charge of PGTCC. I welcome, sir.
Thank you. I think at the outset, I would first like to congratulate Puneet for holding a wonderful meeting, and also thank him for having me here. I don't know, many of you may not know that we started our career in private sector together in the same hospital. He came from PGI Chandigarh, I came from AIMS, and we both got together and set up the cardiology program in what was then the Escorts Heart Institute. And Dr. Pannu was also with us sometime later. And we spent 6 years together, and after that he chose to move to Chandigarh, and I continued in Fortis, what became Fortis Escorts Amritsar, and so it's good to come back and be together again. So moving now to the current guidelines for hypertension, targeting the elderly for optimal outcomes, is actually two talks into one. This means talking about the current guidelines and about targeting the elderly. And I shall try and cover both briefly in the time allotted to me. So hypertension, you know, is a silent killer and is one of the major contributors of CV morbidity and mortality. Its prevalence was about 1 billion in the year 2000, as defined by the BP cutoff of that time, 140/90. Now, of course, it would be much more since the cutoffs have changed, at least in the American Heart Association guidelines. And even with 140/90 cutoff, the number is expected to increase by more than 60% by 2025. Therefore, this is a massive healthcare problem. And as 2/3 of these cases are in the developing countries, this is a bigger problem for us. Further, WHO data tells us that when we look at the mortality attributable to different risk factors, blood pressure is actually the leading risk factor responsible for mortality worldwide. It's responsible for nearly 40% or more of the entire mortality in some form or the other. This is because 54% of the attributable risk of stroke, nearly 47% due to coronary artery disease, and 25% of other CVDs is attributable to hypertension. And this was when we were taking 140/90 as a cutoff. This is again WHO data 2014 showing us the prevalence of hypertension worldwide. And this is India, as you can see, this is not on. Can I get it on, please? India falls in the area of 25 to 30%. That means 25 to 30% of all Indian adults are hypertensive. Considering that we have over 600 million adults, we have at least 200 million people with hypertension or thereabouts. More common, hypertension is even more common than in India in some parts of the world. These includes large parts of Africa, Europe, Russia. These are in the 30 to 40% range, but even India, I think, has the largest absolute number of hypertensives because of its large population. And that's why we are expected to have more than 200 million hypertensives in the next few years. Now, coming to the next step, which is how many people know about their problem and how well their BP is controlled. This is data from USA, the National Health and Nutrition Evaluation Surveys, 4 of them. And this shows that even as recently as 2004, even in US, which is a much more aware population than ours, 70% of people were aware they had hypertension. About 60% of these people were taking treatment. And yet only 1/3 of the patients of hypertension were actually controlled. As expected in India, things are much worse. Barely half the people know they are hypertensive. A lesser number are on treatment, and good control is found in barely 20% or thereabouts, which is a very poor figure. So current challenges as far as India is concerned in hypertension control are that more than half the population of hypertensives is unaware that they have hypertension. Some 2/3 of those who are aware are taking treatment, and only 15% or so are actually well controlled, which means the large bulk of population of hypertension is actually not well controlled. Shifting gears a bit and going on to goals of therapy. Cardiovascular events used to occur above any blood pressure more than approximately 120/80. And we nevertheless were defining hypertension with a cut point of 140/90. And whenever we used to treat patients, our goals were also 140/90. Now, why was this? When we look at data from this study from Framingham in the NEJM, published almost 17, 18 years ago, we found that people who had so-called normal blood pressure were continuing to have a higher risk of CVD events. So this meta-analysis was conducted. It had more than 1 million individuals from over 60 studies, and a follow-up of more than 12 million patient years, found disturbingly that when the blood pressure starts rising from a figure of 115/75, every increase of 20 millimeter systolic or 10 millimeter diastolic actually doubles the risk of getting a CVD event. This meant that at 135/85, which was erstwhile called normal blood pressure, you had a CVD risk which was twice as high as a person who had a blood pressure of 115/75, and so on and so forth. So 155/95 was 4 times higher risk, and 175/105 was 8 times higher risk as compared to what was real normal blood pressure, defined in population studies as 115/75. But as you know, our guidelines were totally different. Last year, this data was published in Lancet. This is a meta-analysis of 123 studies, over 6 lakh individuals, which showed that a 10 millimeter reduction in blood pressure reduces CV events by 20%, coronary artery disease and stroke, heart failure significantly, reduces mortality by 13%. The only condition it did not affect significantly was chronic renal failure. That didn't decrease too much with good BP control, but there was definitely a potential to reduce the risk of cardiovascular events by more than half if blood pressure were to be controlled aggressively and effectively. However, till 2013, these were the hypertension guidelines, wherein everybody below the age of 60 having hypertension, diabetics and CKD had a target blood pressure of 140/90 when controlling hypertension was thought. In those above the age of 60, this goal was relaxed somewhat. I'll tell you why later, but in them the goal was 150/90. And this was across the board, all guidelines, whether American, European, Canadian, ADA, KDIGO, NICE, all of them were recommending more or less similar cutoffs. Now, all this changed with this one trial. I'll be discussing it briefly. This is the SPRINT trial. This was a randomized control trial which recommended that you try and treat hypertension more aggressively. So there were 2 arms, more than 9,000 patients. One half received intensive therapy. That means the blood pressure goal was 120 millimeter systolic. Whereas the other half had a conventional BP monitoring arm, which means that their target blood pressure level was 140. So less than 140, less than 120, 2 arms. Inclusion criteria were all high-risk hypertensives. So this included people over the age of 50 with predominantly systolic hypertension and an additional CVD risk factor, which could be either clinical or subclinical CVD, CKD, which was not severe, that means cutoff GFR of 20, Framingham risk score of more than 15%, or very elderly, age more than 75. So only these high-risk individuals were taken for this study. And major exclusions to be remembered are stroke, diabetes, heart failure, and advanced CKD. These subgroups were excluded from this study. And they found that they were quite successful in maintaining blood pressure in both the arms. So one arm had a mean systolic blood pressure of 136, whereas the intensive arm had a mean blood pressure of 121. And they found that doing this significantly reduced CVD events. This had been shown for the first time. These were relatively startling results of this study. So they found that achieving target systolic blood pressures of 120 millimeter mercury reduces CV events and strokes by 25%, heart failure by 38%, and CV death by 43%. And this was quite a strongly positive trial, I think one of the strongest trials in the last 5 or 10 years. Here I would like you to see that in all pre-specified subgroups, intensive treatment was better, but I would draw your attention here, because this is the second part of our discussion today, age. As you can see, people who were over the age of 75 actually benefited even more with more aggressive blood pressure control than people over the age of, below the age of 75. And when this data was combined with the diabetes patients in ACCORD, as you might remember, SPRINT excluded diabetes, but ACCORD had diabetes with and the diabetic patients in ACCORD in the more intensive blood pressure control arm, which was similar to the SPRINT trial, there was a greater reduction of stroke, of heart failure, and of the combined endpoint in the intensive treatment arm, thus confirming that the benefits of SPRINT were also there for diabetic patients. So the next guidelines, which came up in